Hey everyone, today we are going to do clinical psychology from the Cambridge A-level syllabus. Clinical psychology consists of 5 main topics. First, which is schizophrenia, second, mood disorders, impulse control disorders, anxiety disorders, and lastly, obsessive compulsive disorders. In this video, we will cover the content of schizophrenia from the A-level syllabus. I'd really appreciate if you like the video, and if you have any questions regarding the video, feel free to comment down below and I will answer them. So let's start off with what schizophrenia actually is. It is a psychotic disorder, a severe psychotic disorder, where an individual has a major breakdown from reality and perceives the world differently than others. Now, every other disease and every other disorder have their symptoms, such as a sore throat has the symptom of coughing or itchiness in the throat. Similarly, schizophrenia has its symptoms, and they are categorized into 2 types, which is positive and negative. The positive symptoms are the main symptoms. They are the main symptoms. These include persistent delusions, which means when you hold a strong belief about something that isn't true or that isn't based off reality. For example, you have a psychology test coming up and you never prepared psychology in your whole life. So you strongly believing that you'll ace the test is you being delusional. It is a delusion. So schizophrenic people have a lot of strong beliefs about things that are not based off reality or are not true, and they are persistent, meaning they happen reoccurringly and again and again. Second is persistent hallucination. This can be of 2 types, auditory or visual. Now, auditory hallucination means an individual can hear things that are not heard by other people, and an individual can see things which are not seen by other people, which is the visual hallucination. So, for example, a schizophrenic person is alone in an empty room. So, if they hear people talking in the room, that is auditory hallucination. And if in that empty room they can see people, which is not in reality, there's no one in the room. But if they can see people, that is visual hallucination. Third is thought disorder. Thought disorder means that the individual cannot talk or think or speak in an organized manner. Their thought process is very disorganized. They might be talking about death and then suddenly about parties and then suddenly about the future, not completing what they were talking. This is something that's also in ADHD. Meaning switching between topics very quickly. It shows how disorganized the thinking process is, which leads to a disorganized way and manner of speaking. Then fourth is experience of influence or control. A schizophrenic person believes that their behaviors and actions are being controlled, or that something took over them and it's something external, that they don't have any free will in what happens or the actions that they do. For example, a schizophrenic person pushed someone down the stairs. They might say that something took over them or that they're being controlled by someone, and that action was not actually theirs and it was something else or some external force. These are the positive symptoms of schizophrenia. There are a lot more symptoms, but these are the easiest to learn. Then comes the negative symptoms of schizophrenia. Avolition means lack of motivation. This is also a symptom of depression. Lack of motivation means, for example, you want to study, but there's nothing pushing you to do it. You don't want to do it, even though you know it's important, but there's nothing really pushing you or letting you know that how important it is. So that is the lack of motivation. It can be lack of motivation to do a task or anything. So schizophrenic people have the lack of motivation. they have flattened affect, which means a blunted emotional expression, meaning a serious face that looks like this. So, for example, at a death of a very close family member, they might have that face on, while everyone else might be crying or sad. Or maybe at a party where everyone's smiling and laughing, they might have the serious expression on, meaning they're not showing any emotional expression through their face, and they just have a serious face on. Then is impaired cognitive function. This means reduced memory and reduced attention. So, a schizophrenic person cannot recall properly. They might have a short-term memory, and they cannot really pay attention to, for example, if you're speaking, they might get distracted very easily. It's something that is also, again, common in ADHD, meaning lack of memory and attention. Catatonia refers to lack of movement and speech, meaning a schizophrenic person might sit in one place for a very long time, and they might not initiate conversations, speak very less, such as introverted people that do not talk a lot. So they might stay quiet for longer periods of time and not interact with people. It can also lead to social withdrawal, meaning completely shutting yourself off from other people. So these are the two types of symptoms of schizophrenia. The positive ones are the main symptoms. Here is another picture which shows the symptoms of schizophrenia. Now we are going to do the study by Freeman et al. In 2003. And this is a key study, which means it is a very important study to learn. The context of the study is what virtual reality actually is. It is a computer-generated environment. You have your real-life environment, and once you wear a headset, a virtual reality headset, there is a computer-generated environment around you that is not real, and only you can see it since you're wearing the headset. Other people that are not wearing the headset won't be able to see that environment. So it was a new technology introduced in the early 2000s, and it was used for different type of things, such as social interactions, exposure therapy, and to help reduce fear of public speaking. And it was also shown useful in treating psychological disorders. Thus, Freeman wanted to see if it could be useful in treating symptoms of schizophrenia. Now, the main theories and explanations is persecutory ideation. What is persecutory ideation? It is a belief that people think negatively about you or that they're being rude towards you. For example, you are in a classroom and no one is interacting with you. If you start to think that people hate you, that they don't like you, that they're being rude towards you, that is persecutory ideation. A normal person can also have these type of thoughts. But for schizophrenia, this is a common symptom. So it happens very commonly. A schizophrenic person will have persecutory thoughts nearly all the time. Now, the aim and hypothesis of the study. First, Freeman wanted to investigate whether participants without mental illness, that do not have a history of mental illness and never experienced a mental illness. He wanted to see if these people have thoughts of persecutory ideation, negative belief about other people in a computer-generated environment. He then also wanted to find out whether there are cognitive or emotional factors that cause persecutory ideation to be shown in virtual reality. He wanted to see that is persecutory ideation caused by any factors such as cognitive and emotional. He wanted to see if they're caused by these two factors. Then lastly, there was a hypothesis that for sure, a small number of participants would experience persecutory ideation or persecutory thoughts. And these small number of participants would have higher levels of emotional distress or paranoia. Now, the sample of the study was a total of 24 participants. There were 12 females and 12 males, an equal number of both genders. Now, nearly all of them were students and 3 of them were administrative staff. So basically, 21 participants were students and 3 of them were administrative staff from the University College London UCL. The average age of all participants was 26 years, and they were recruited through volunteer sampling. So an advertisement was passed around in the college, and they were recruited through volunteer sampling. Now, when you give an advertisement and you volunteer sample, that means the person has volunteered and has given their informed consent to participate in your study. Now, this was a correlation study, and this experiment took place in a laboratory. Quantitative data was collected through a lot of questionnaires, and one of them is Brief Inventory Symptoms, BSI. Others measured anxiety, paranoia, sense of presence. These were all like different questionnaires, but if you want to learn the name of one, so you can learn this name, Brief Inventory Symptom, BSI, is a 53-item questionnaire. Now, qualitative data was also collected through semi-structured interviews. The procedure of the study was that, first of all, before the experiment even started, participants were first trained how to use the VR. In case someone didn't know how to use it, so first all of them were trained how to use it. And then they were asked to enter a virtual environment, a computer-generated library scene. A library scene that was computer-generated for a total of 5 minutes, just 5 minutes. And in that library scene, there were 5 avatars. One sitting in a group of 3 and one sitting in a group of 2. So they sat in 2 small groups, a 3-1 and a pair. And they would occasionally smile at the participant that entered that virtual environment. They would smile at them or look over at them or talk to one another. So the participants were asked to enter the virtual environment for 5 minutes, and they were asked to explore the library and to form some impressions about those 5 avatars and what they think about them. And what do those 5 avatars think about them? So what do they think about the avatars, and what did they think that the avatars thought about them? So this was a task given to the participants to do in those 5 minutes. Now, the results that were found, it was that there was a significant correlation between scores on paranoia questionnaire and the paranoia score that was given based on the semi-structured interview. So in the interview, the person conducting the interview gave a score to each participant, a paranoia score. Like based on the answers the participant gave in the interview, they were given a paranoia score. And that paranoia score significantly correlated with the score of their paranoia questionnaire that was given. Most participants had a positive opinion about avatars. Most of them had positive opinions, meaning they did not have persecutory thoughts, and only a few had ideas of persecution, which was the hypothesis given up here, that they hypothesized that a small number of participants would have persecutory thoughts. And in the results, it is true. So most participants had positive, whereas only a few had ideas of persecution. So the persecutory thoughts that the few people had, it did not correlate with the paranoia score. So there was no correlation between the persecutory thoughts and the paranoia score. However, there was a significant correlation between the anxiety and interpersonal sensitivity. So the scores of these significantly correlated with the persecutory thoughts, which leads to a conclusion that a person who has higher levels of anxiety and interpersonal sensitivity means that they are more likely to have persecutory thoughts as well. Now we are going to evaluate the study, meaning what are the strengths and the weaknesses of the study. First is reliability. It was a strength, meaning the study was reliable. And why was it reliable? Because a standardized approach was used. And that was the use of a VR program. A VR program is computer generated, meaning it is less likely to have human error or maybe extraneous variables, etc. So therefore, it was a standardized approach. Second is the use of quantitative and qualitative data. Quantitative data allowed for objectivity, whereas qualitative data allowed for subjectivity and to understand the participants' thoughts and feelings. Now, quantitative data allowed for central tendency to be calculated, and qualitative data allowed for thematic analysis. And these are important terms that you can learn and include in your answers. And both of them therefore allowed for a good data analysis, which is very important to draw meaningful conclusions. However, there was a weakness in this. And what was the weakness? It is a self-report. Those questionnaires were self-reports, and the participant may lie in those questionnaires, maybe to seem more socially desirable, or maybe that they're embarrassed to admit a few things, and this may lead to response bias and demand characteristics. They might want to look more desirable to the researcher. This can lead to social desirability. So therefore, the scores might not be right, and this can lead to a validity issue and reliability issue of the results of the study. Now, another strength of the study was validity. How was the study validated? There was use of control. Now, half of the participants, they completed the questionnaires, like the BSI questionnaire and all the other questionnaires. They completed the questionnaires before the study started and after the study. So half of them, so there were 24 participants in total, so basically 12 participants completed the questionnaires, all of them, before and after, whereas 12 participants completed the study only after the study. So 12 completed it before and after, whereas 12 completed it only after the study. And this was a control used so that any extraneous variables could be omitted, and therefore the study could be more valid to see if a change is actually, because you're testing their anxiety and interpersonal sensitivity before the study, and you're seeing if there's a change after. So that is a control used, thus making the study valid. Now, generalizability was both a strength and a weakness. It was a strength because equal number of female and male participants were used, so there was no gender bias. As discussed in the sample before, there was 12 males and 12 females, so no gender bias and equal number of both genders were used. However, the sample was relatively small. It was just 24 participants, meaning it cannot be representative of a whole population. And they were all from the same university. Freeman could have used participants from different type of universities, because a same university, maybe the participants all of them think in a similar way because they're in the same university, and volunteer sampling was used, meaning they were willing to participate in the study. They had interest in the study. What about those people that don't have interest in this thing? Therefore, it is not representative of the whole population or the public of that city. It is not representative enough. Second last is ethics. Now, ethics, again, it has a strength and a weakness. In strengths, it was that participants gave consent. Volunteer sampling was used, meaning they were willing to participate and they gave their consent. And they were also told that they had the right to withdraw, so if they felt uncomfortable or distressed, they could withdraw from the study. Whereas the weakness of the study is that participants who scored high on the anxiety and paranoia score, that means they were anxious during the study because they scored high on anxiety. So they may have been distressed and anxious, which means that psychological harm was given to those participants, and therefore it breaks the ethical guidelines and is a weakness of the study. Lastly is ecological validity. A computer-generated environment was used, a simulated environment, and that is different from real life, meaning the participants were put in a library scene which isn't even based off real life. It was simulated. So participants may have acted a different way if they were in real life. Therefore, this is also a weakness of the study and may have impacted the results. So this is the whole Freeman study, and you have to learn the evaluation and the results, the procedure, and everything, because you can be questioned about this on your exam. Now, in explanations, there are 3 explanations. There's biological explanations, there's biochemical explanations, and lastly, there is psychological explanations, also known as cognitive explanations. Biological explanations refers to like genetics, your genes. It might have been passed on to you by a family member, or you might have it because your twin has it. So on biological explanations, 3 types of studies were done. There were 2 studies and 1 research. First is family studies. So it is believed that individuals who have a close family member that has schizophrenia are more likely to develop it. So for example, if you have a close family member that has schizophrenia, you are more likely to develop it. An example study is by Goetzman. He did a twin study in which the likelihood of developing schizophrenia went from 1% up to a 48%, a 47% increase in likelihood of schizophrenia if you have an identical twin with it. In twin studies, first let me clear what are monozygotic and dizygotic twins. Monozygotic twins share 100% of their DNA, whereas dizygotic twins share 50% of their DNA. So the concordance rate of schizophrenia is higher in monozygotic twins because they share 100% of their DNA, and more than in dizygotic because they share 50%. So a example study was done by Hilker in 2017. He did a twin study on 30,000 twin pairs in Denmark, which concluded that the heritability of schizophrenia was 71%. Heritability. And this is related to genes. So you inherited schizophrenia. Again, biological. Lastly is contemporary research. Now, schizophrenia is a very complex disorder, and understanding the genes related to it is a very complex procedure. Now, there are thousands of gene variants that are linked to the condition, the disorder, schizophrenia. And thus, these thousands of gene variants are referred to as polygenic. These thousands of gene variants that are linked to schizophrenia are referred to as polygenic. Now, these gene variants that are known as polygenic, these gene variants are linked to proteins. And these proteins are responsible for the development, transmission, and breakdown of neurotransmitters. What is an example of a neurotransmitter? Dopamine. Dopamine is an example of a neurotransmitter. And dopamine is responsible for like your motivation level, your happiness and everything. It can affect your mood if it is low. And thus, the protein is responsible for the development of it, for the transmission of it, and for the breakdown of it. So if it does not develop the neurotransmitter properly, does not transport it properly, does not break down it properly, so it can cause neurochemical imbalances within the body, and this is associated to schizophrenia. So once again, this is a bit of a tricky part, but it is easy when you understand it. So thousands of gene variants that are linked to schizophrenia, these thousands of gene variants are known as polygenic. Now these gene variants, they are linked to proteins, and these proteins are responsible for the development, transmission, and breakdown of neurotransmitters such as dopamine. Now if they do not do their job properly, they are thus responsible for the neurochemical imbalances which are associated with schizophrenia. And this is the whole biological explanation of schizophrenia. Moving on to the biochemical explanation of schizophrenia, there are 3 of them. Dopamine hypothesis, which refers to the excessive amounts of it. Dopamine deficiency hypothesis, which means that there's a lack of dopamine. And then there is positron emission tomography, PET. And I'm sorry if I pronounced that wrong. So dopamine hypothesis is that basically is believed that if there is an excessive amount of dopamine or dopamine receptors, they are linked to the positive symptoms of schizophrenia. So for example, it has been researched that an increase of dopamine in certain brain regions, such as the Broca region in the brain, can impair logical speech, meaning you won't speak properly. You'll speak in a disorganized way. And we learned this before. It is a symptom of schizophrenia, thought disorder, not talking in an organized way. Second is the dopamine deficiency hypothesis. Over here, we talk about the excessive amount of dopamine receptors. In this, there is an excessive amount of receptors. But why are there excessive amount of dopamine receptors? This is because there's a low level of dopamine. And when there is a low level of dopamine, the brain compensates for this. How does the brain compensate? It increases the number of dopamine receptors. Because of the low level of dopamine, the brain compensates and increases dopamine receptors in the postsynaptic cell, and this is known as upregulation. Now, when there's increase in dopamine, this is linked to schizophrenia. And how? What is the evidence that this may be linked to it? Post-mortem studies were done on deceased individuals that had schizophrenia, okay? And when post-mortem studies were done on these deceased individuals that had schizophrenia in their life, the brain scans of these people showed that they had a large number of the dopamine receptors, which brings us back to the theory, which is dopamine deficiency hypothesis, which shows when you have a low level of dopamine, the brain increases the number of the receptors. And in the post-mortem studies, it was shown that people that had schizophrenia in their life, their brain scan showed that they had a larger number of dopamine receptors in their brain. Lastly is positron emission tomography, PET, and this is a scan. It's a scan that helps you show when there's a greater dopamine activity in the brain, in regions such as the striatum, which is linked to positive symptoms of schizophrenia. It can show you when there's a greater dopamine activity, and it can also show you when there's decreased dopamine activity. And this was actually researched by Nestler, and again an example study, very short and brief, which is linked to negative symptoms such as flattened effect. So using this scan, Nestler identified that there was a decreased dopamine activity. And this is linked to negative symptoms such as flattened effect, meaning blunted emotional expression, which we learned again in the symptoms of schizophrenia. Last explanation of schizophrenia is psychological cognitive. So for this, there was an example study done by Fritz, and this is a very interesting example study. Now, what Fritz says is he believes that schizophrenia is a faulty mental process that the person who has schizophrenia has a problem with how they think and perceive things. Their mental process is faulty. So there were 3 things that he researched on. First was abnormality of self-monitoring. So the patient with schizophrenia fails to recognize if the perceived hallucinations are in fact just their inner speech. Now, everyone has a voice in their head. If you stop speaking and you start thinking in your head, doesn't that seem like inner speech to you? Well, Fritz thinks that patients that have schizophrenia, they think of that inner speech as hallucinations. They don't believe that's their own inner speech. They think that it's something external, and thus it's a hallucination. They imagine things and they think it's actually there. It's not their imagination, and thus it's a hallucination. So they cannot really differentiate what is their inner speech and what is like what's in the environment. So therefore their imagination and their inner speech, they perceive it as hallucinations. And this was done, a task was given to participants in which a few words or something, they were read out by a computer and then by a researcher, and the patients read it by themselves. And they wanted to see whether the patient recognizes whether it's being read by the computer or a researcher or by themselves. And the people with schizophrenia, they performed worse at that task because they could not really identify who is reading it. They'd think of it as hallucinations. They don't know if the computer's reading it, if the researcher's reading it, or if they're reading it themselves. Second is the misinterpretation of perception, in which the patient applies logical reasoning to their hallucinations. Now they're hallucinating something and they're going to apply logical reasoning to it to make a strong belief about it. This is also like delusionals, which we read in the positive symptoms of schizophrenia, persistent delusions. So the participant applies logical reasoning to it, and they strongly believe in those things. For example, alien control. They'll apply their logical reasoning to those things, and it's just even more stronger. That symptom becomes even more stronger. Their delusions become even more stronger. Their beliefs become stronger because they applied their logical reasoning to it. And lastly is difficulty mentalizing. Now this is something that was also studied in people that have autism, and is also been studied in their syllabus in Baron Cohen. So schizophrenic people, they find it difficult to make decisions, to behave, and what to do or how to speak or what conversation to make. However, if they're given a prompt, if someone else starts the conversation, they can perform well. However, they cannot initiate it. They cannot make decisions. If someone makes their decisions for them, then they can behave properly. If someone initiates a topic and starts talking to them, they can do it properly. However, they themselves cannot make the decisions. They themselves do not know how to behave, and they themselves do not know how to talk to people or initiate a conversation. So therefore, they need a guide at all times to help them make the decisions, to help them tell them how to behave, to tell them what to talk about. Now, why is this? Why does this occur in schizophrenic people? This may occur due to impaired theory of mind. Theory of mind. This refers to person lacking to recognize the intentions of other people. So in front of you is a person and they're trying to, maybe by their social gestures or by their body movement or eye movement, they're trying to convey something, but you cannot just understand it. That's a problem in autism. Autistic people cannot really understand a person through their body language or eye movement or social gestures, body gestures. And this is also a thing in schizophrenic people. They have a problem in recognizing the intentions of other people. And this leads to social withdrawal and lack of speech, which is a symptom of schizophrenia. Lack of speech and lack of movement is a symptom of schizophrenia. and so is social withdrawal, which is also linked to lack of speech. And these are all the explanations of schizophrenia. If you want these proper notes, please comment down below to requesting for the notes, and I'll send them to you by email. Now moving on to the treatment of schizophrenia. Again, there's a biochemical treatment for it, there's a biological treatment for it, and there's a psychological treatment for it. Just like in the explanations, there was a biological explanation, biochemical explanation, and psychological explanation. In treatments, there's also biochemical, biological, and psychological. In biochemical, it is drugs. Drugs are what are going to affect the chemicals in your body. And there are two types of drugs that help with schizophrenia, that help in the treatment of schizophrenia. And these are typical antipsychotics and atypical antipsychotics. Typical antipsychotics were introduced first, way before atypical, and they are known as first generation, and they were introduced in the 1950s. An example of it, which you can learn and it will be helpful in your exam answers, is chlorpromazine. This is a picture of what it looks like and what the schizophrenic people might take. So this is an example of what a typical antipsychotic looks like. Now these are dopamine antagonists, therefore they block the dopamine receptors and reduce the effects of dopamine. However, they have more risk, a lot of risk within them compared to atypical antipsychotics. Atypical have a lower risk than typical antipsychotics, and these are referred to as second generation. An example of it is clozapine, which looks something like this, and they're an effective treatment for people that are treatment resistant. Treatment resistant people are those that continue taking a drug and they become resistant to that drug, they become used to that dosage, that drug, and thus that drug does not really affect them. So this type of atypical antipsychotic is effective for people that that are treatment resistant. Why is atypical antipsychotics have less risk than typical antipsychotics? Now this is because they block dopamine and then they rapidly dissociate, which allows for normal dopamine transmission. In typical antipsychotics, the dopamine receptors are blocked. Okay, they are blocked. There's no dissociation after. Whereas in atypical antipsychotics, they block it and they rapidly dissociate, which allows for normal dopamine transmission. So the normal body function is still being carried out because it just blocks it temporarily so that the symptoms of schizophrenia are reduced. So it's temporarily blocked and then rapidly dissociate so that normal body function, normal dopamine transmission can be carried out, and thus it is of a lower risk. This is not the case in typical antipsychotics. And atypical antipsychotics, they have a beneficial effect on both the negative and the positive symptoms of schizophrenia. So positive are like the more main symptoms, and then the negative symptoms as well. So antipsychotics have a beneficial effect on both types of symptoms. Now for the biological treatment, there is electroconvulsive therapy. And this question, the question of treatment of schizophrenia on electroconvulsive therapy and on cognitive behavioral therapy, has been asked in the May-June exam of Psychology P3 2024. Now in electroconvulsive therapy, this involves delivering an electrical pulse of 70 to 150 volts. And what is the purpose of this? What is the purpose of delivering this? It is to induce a controlled seizure which lasts up to 1 minute. Now this is what it may look like. Electrodes are placed on the scalp and a seizure is induced in the patient. Now, this treatment may be from 6 to 12 sessions, and typically there are 2 sessions during a week. And electroconvulsive therapy is used in addition to medication. This is done for people who are treatment resistant. An example of electroconvulsive therapy, when it was used in the study done by Aneja et al. 2018, in which a young boy he got early onset schizophrenia in a younger age, in which it should not have come, but it came in an early age. And then for his treatment, he received 8 sessions of bilateral, both sides of the brain, electroconvulsive therapy in his treatment. But that was later on in his life. It is believed that in electroconvulsive therapy, the electrical shocks that are delivered, it is believed that they release neurotransmitters such as dopamine and serotonin. And when these both are released, this helps reduce the symptoms of schizophrenia. And these seizures are associated with gene expression and improved connectivity between the neurons in areas such as the hippocampus. It is an effective treatment. However, little research has been done on this electroconvulsive therapy, and it has its ethical issues because patients are sometimes harmed during the electroconvulsive therapy, and that can result in even broken bones. Lastly is the psychological cognitive treatment to schizophrenia, and this includes cognitive behavioral therapy. Cognitive behavioral therapy is a talking therapy, and it helps the patient recognize their thoughts and challenge their thoughts that are responsible for their certain type of behaviors. So in cognitive behavioral therapy, a patient will tell the therapist their thoughts, that, for example, I have this problem, or I have negative beliefs, that people think that I'm weird, or they don't like me, or they hate me, and the therapist is going to help them recognize their thoughts. They're going to help them challenge their thoughts. They're going to question them, that why do you feel this way? How can it be made better? And all that. So it is a talking therapy, and it is almost always used alongside antipsychotic drugs. Now, an example study was done on the use of cognitive behavioral therapy to see how useful it was. It was done to compare the effectiveness of cognitive behavioral therapy with a control group. So that means that one group was receiving the therapy, and another group, which was the control group, they were not receiving the therapy. And this was an example study done by Sensky et al. In the 2000s. So a randomized control trial was used, and there was a sample of 90 patients with treatment-resistant schizophrenia, and they received a mean average of 19 CBT sessions, or befriending sessions. So these 90 participants, they were randomly allocated to either the CBT session or to either the befriending session. So thus this was an independent groups design. Now this helped for lower risk of participant variables. Participants were assessed by blind raters before and after, and at a 9-month follow-up, so therefore it was longitudinal. It was done over a long period of time. The treatment was of 19 CBT sessions done over a period of weeks, and they were assessed before and after the treatment and at a 9-month follow-up. And these blind raters, they did not know if the participants belonged either to the CBT group or to the befriending group, therefore reducing researcher bias or rater bias. Now, both groups, both the befriending and the cognitive behavioral therapy group, they showed an overall reduction in their symptoms. However, in the 9-month follow-up that was done, the improvement of symptoms that they showed before, the improvement of symptoms remained in the CBT participants, meaning that the participants of the befriending session, their improvement did not last up to 9 months. However, the CBT participants, their improvement lasted up to 9 months. Therefore, it can be concluded that CBT is actually a helpful treatment for schizophrenic patients alongside with their antipsychotic drugs. And this is the end of the topic of schizophrenia, the treatments, the explanations, the important case study, and a basic explanation of what it is. Thank you for watching the video. I really like if you subscribe as well, and please comment down below if you want me to complete the whole of clinical psychology and also make easy notes on health psychology and videos about it too.